Most people believe that knee replacement surgery is one of the safest, most predictable operations in modern medicine. The brochure shows a smiling patient walking in a park 3 months after surgery. The surgeon is confident. The waiting list is long because demand is high. If it were not working, surely fewer people would be having it. I used to present it that way too, until I started looking at the numbers that do not appear in the brochure. A 6-7-year-old retired teacher who had knee replacement surgery and spent the following 14 months in more pain than she had experienced before the operation. A 71-year-old man whose surgery was technically successful by every measurable standard: implant positioned correctly, infection-free, clean recovery, and who told me 18 months later that he wished he had never agreed to it. Not because something catastrophic happened, because nobody had told him what recovery would actually demand from a body carrying his specific health history, and because nobody had told him that for patients over 65 with his profile, the failure rate was significantly higher than the number his surgeon had quoted. Here is what I have learned after 2 decades in surgical medicine. The overall success statistics for knee replacement are real. They are also incomplete. They average together patients in their 50S and patients in their 70S, patients with 1 health condition and patients with 5, patients with strong physiological reserve, and patients whose bodies are operating with significantly diminished capacity to heal. When you separate those groups and look at outcomes specifically in patients over 65 with multiple comorbidities, the picture is meaningfully different from what most patients are shown before they sign. My name is Dr. James Andrews. I am a cardiothoracic surgeon with over 2 decades of experience in surgical medicine. Today, I am going to tell you what the preoperative consultation on knee replacement frequently leaves out: the failure rates, the risk factors, the recovery realities, and the alternatives that for many patients over 60 represent a genuinely better path than surgery. And I am going to give you the specific questions that can change the outcome of any surgical consultation before a date is ever scheduled. I have spent over 20 years inside operating rooms and in the conversations that surround them before procedures and after them, particularly the conversations that happen when outcomes do not match expectations. What I have observed consistently across 2 decades is that the gap between what patients are told before elective surgery and what they experience during recovery is wider for patients over 65 than for any other surgical population. I am making this video because that gap is closable not by changing the surgery, by changing the conversation that happens before it. Informed patients over 65 who ask the right questions before agreeing to knee replacement make better decisions, experience better outcomes, and are far less likely to find themselves on the wrong side of statistics that nobody quoted to them before they signed. But before I walk you through the specific failure rates and risk factors, I need to give you a framework that makes everything else make sense. Knee replacement surgery has an overall long-term success rate that is genuinely impressive, roughly 90% at 10 years. When you look at the entire surgical population, that number is accurate. It is also for patients over 65 with significant health conditions, misleading in a way that matters enormously. Here is why. That 90% figure is a population average. It includes 5-year-olds with isolated knee arthritis and no other health conditions. It includes 6-2-year-olds with strong cardiovascular function and excellent physiological reserve. When you pull those patients out of the data and look specifically at outcomes in patients over 65 with 3 or more comorbidities: heart disease, diabetes, obesity, chronic kidney disease, peripheral vascular disease, the success rate drops significantly, the complication rate rises significantly, and the functional recovery, meaning how well the patient actually moves and functions in daily life after surgery, falls significantly short of the average outcomes that appear in patient-facing materials. This is not a conspiracy or a failure of medical ethics. It is a statistical reality that gets lost in the way outcome data is communicated to patients. The number your surgeon quotes is real. It just may not be the number that describes your outcome. And the difference between those 2 numbers is what this video is about. Think of it this way. Your body's capacity to recover from major surgery depends on what I call physiological reserve, the fuel tank of healing capacity. At 50, with no significant health conditions, that tank is full. Knee replacement draws heavily on it, but the tank refills at 68 with controlled diabetes, early kidney disease, and a history of cardiac events. That same tank is operating at a different level. The surgery draws the same amount of fuel. The refill is slower, less complete, and more vulnerable to interruption from complications that a fuller tank would have managed without incident. Understanding your own tank, your own reserve, before agreeing to surgery is the most important preparation any patient over 65 can do. And it begins with understanding the specific ways knee replacement can fail in patients with your profile. The statistic most patients hear before knee replacement is the success rate. The statistic most patients are not given with equal emphasis is the revision rate, the percentage of patients who require a second operation because the first one fails, wears out, becomes infected, or fails to deliver the functional outcome the patient needed. In the general knee replacement population, the revision rate within 10 years is approximately 5 to 8% for patients over 65 with multiple comorbidities. That rate is meaningfully higher. Obesity significantly increases implant stress and revision risk. Diabetes impairs wound healing and dramatically raises the risk of periprosthetic joint infection. Infection around the implant itself, which is one of the most serious complications in all of orthopedic surgery, and frequently requires complete implant removal followed by a prolonged course of intravenous antibiotics before any revision surgery can be attempted. Peripheral vascular disease, reduced circulation in the legs, which is common in older patients with cardiovascular risk factors, impairs wound healing after knee surgery in ways that can lead to wound breakdown, chronic drainage, and infection. The knee incision requires robust blood supply to heal cleanly. A patient with compromised peripheral circulation is beginning that healing process with a meaningful disadvantage. A major analysis published in the Journal of Bone and Joint Surgery found that patients with 3 or more comorbidities had significantly higher rates of major complications, prolonged hospital stays, and revision surgery compared to patients without significant comorbidities. This data exists. It is published. It is not routinely communicated to patients during pre-operative consultations with the same emphasis as the overall success statistics. Before agreeing to knee replacement, ask your surgeon directly, what is your personal revision rate for patients with my specific health profile, not the national average? Your rate in patients like me. That question, asked directly, will tell you more about what lies ahead than any brochure. Have you or someone you love been given a knee replacement recommendation? Tell me what that consultation looked like in the comments. General anesthesia in patients over 65 carries a risk that is almost never included in the pre-operative conversation for elective knee replacement, post-operative cognitive dysfunction. A temporary but sometimes prolonged disruption of cognitive function, memory, concentration, processing speed, executive function that occurs after major surgery under general anesthesia in patients over 70. Post-operative cognitive dysfunction occurs in approximately 25 to 40% of cases to some degree. In most patients, it resolves within weeks. In a meaningful percentage of patients, particularly those with any existing mild cognitive impairment or early dementia that may not have been formally diagnosed, it does not fully resolve. The surgery accelerates cognitive changes that were already underway, and the patient who comes home from the hospital is noticeably different from the patient who went in. This is not a theoretical risk. I have seen it in patients whose families had no idea it was a possibility. Families who attributed the change to the medications, to the stress of hospitalization, to any explanation other than the surgery itself because nobody had told them this was a known and documented complication. For knee replacement specifically, regional anesthesia, spinal or epidural block significantly reduces the cognitive risk compared to general anesthesia and is appropriate for many patients. Ask your anesthesiologist before surgery, is regional anesthesia an option for me, and what is the evidence on cognitive outcomes compared to general anesthesia in patients my age? That conversation should happen before the surgery date, not the morning of the procedure. Here's a statistic that belongs in every preoperative knee replacement consultation and appears in almost none of them. Approximately 15 to 20% of knee replacement patients report chronic pain after surgery, pain that persists beyond the expected recovery window, sometimes permanently, not pain from a complication. Not pain from a failed implant, a chronic pain from a technically successful knee replacement in which everything went as planned. This phenomenon called chronic post-surgical pain is not fully understood. What is understood is that it is more common in patients with certain risk factors: preoperative anxiety and depression, chronic widespread pain conditions, high preoperative pain sensitivity, and longer duration of preoperative pain. Many of these risk factors are more prevalent in older patients who've been living with knee arthritis for years. 1 in 5 patients living with chronic pain after a surgery, they were told, had a 90% success rate. That is the gap between the population statistic and the individual outcome that I believe every patient deserves to understand before signing. What should you do with this information? Ask your surgeon, what is the risk of persistent chronic pain after this surgery for someone with my specific pain history and health profile? And ask your primary care physician whether a psychological assessment for pain sensitivity before surgery would be appropriate. Some specialized orthopedic centers now conduct preoperative pain sensitivity assessments specifically to identify patients who are at elevated risk for chronic post-surgical pain. That assessment can change the surgical decision and should be part of the conversation. The brochure shows a patient walking in a park. The clinical definition of surgical success is implant survival. The prosthetic joint remains in place and functional. What the brochure does not show, and what clinical success statistics do not capture, is what percentage of patients achieve their preoperative functional goals walking without a cane, climbing stairs without holding the railing, returning to recreational activities, living independently. Studies examining patient-reported outcomes after knee replacement, asking patients whether their expectations were met rather than whether the implant survived, show a meaningful satisfaction gap, particularly in older patients with high preoperative expectations and multiple comorbidities. One large analysis found that approximately 20% of patients were not satisfied with their knee replacement outcome, even when the surgery was technically successful. Not because of complications, because the functional improvement did not match what they had been led to expect. For patients over 65 with cardiovascular disease, diabetes, or significant deconditioning, the physical therapy demands of post-operative knee replacement recovery are substantial. 3 to 4 sessions per week for weeks. Exercises at home twice daily. A degree of pain and effort during rehabilitation that many patients find exceeds what they were prepared for. Patients who are already physically deconditioned before surgery face a harder rehabilitation and achieve less complete functional recovery than patients who entered the surgery in better condition. This is the argument for prehabilitation: a formal, supervised program of physical conditioning, strength building, and health optimization undertaken before surgery specifically to improve recovery outcomes. The evidence is clear and consistent. Patients who complete structured prehabilitation programs before elective knee replacement have shorter hospital stays, faster return to functional mobility, lower complication rates, and higher satisfaction with outcomes. Some forward-thinking orthopedic centers now require it for patients over 65 with significant comorbidities. Ask your surgeon before scheduling, what prehabilitation program do you recommend before surgery, and how long should I spend in it to optimize my recovery outcomes? If prehabilitation has not been discussed, raise it yourself. The conversation it opens is among the most valuable in the entire preoperative process. Here is the piece of information that I believe represents the largest gap in most preoperative knee replacement consultations for patients over 65 with moderate knee arthritis, not end stage, not bone-on-bone complete joint destruction. There are non-surgical alternatives that in well-designed comparative studies produce outcomes equivalent to surgery at 2 years, with dramatically different risk profiles. A landmark study published in the New England Journal of Medicine comparing knee replacement plus physical therapy to physical therapy alone in patients with knee osteoarthritis found that physical therapy patients achieved meaningful functional improvement, with a significant percentage crossing over to surgery within 2 years, but many others maintaining satisfactory outcomes without it. The study raised a question that the orthopedic community has engaged with seriously ever since. How many of the knee replacements performed each year are being performed in patients who would do equally well, at least in the medium term, with an optimized non-surgical program? The non-surgical options that deserve specific discussion before any knee replacement recommendation is accepted include A structured, supervised physical therapy program targeting quadriceps and hip strengthening, specifically not generic exercise, targeted rehabilitation. Intra-articular corticosteroid or hyaluronic acid injections for symptom management. Weight optimization, because every pound of body weight reduction decreases knee joint load by 4 pounds. Activity modification and biomechanical assessment, and for appropriate candidates, newer biological therapies, including platelet-rich plasma injections, the evidence for which continues to develop. None of these options is appropriate for every patient. End-stage arthritis with complete cartilage loss and severe functional limitation surgery is frequently the right answer, and I would never suggest otherwise. But for patients in the moderate range, the question of whether surgery is the right answer right now for this specific body is a question worth sitting with before a date is set. Ask your surgeon, for a patient with my specific imaging findings and my specific health profile, what would a structured 6-month non-surgical program look like, and what functional outcomes would you expect? If that question is dismissed without a substantive answer, seek a second opinion from a physician who specializes in non-surgical orthopedic management before you commit to surgery. I want to say something that the data cannot say by itself. I have been in medicine long enough to have reviewed outcomes on patients who had surgeries I was not involved in. Patients whose charts I encountered years later as part of institutional quality reviews. And the pattern that stays with me most is not the dramatic failures, the infections, the revisions, the catastrophic outcomes that generate incident reports and morbidity conferences. Those are painful, but they are visible. The system sees them and responds to them. What the system does not consistently see is the quieter outcome to the patient who is technically a surgical success. The implant is functioning, the wound healed, no complications on the chart, and the patient is sitting in a follow-up appointment telling their surgeon that they are not better, that the recovery was harder and longer than they were prepared for, that they are in pain they were told would be gone by now, that they wish someone had told them what the process would actually look like before they agreed to it. That patient does not show up in the failure statistics, and that patient, in my experience, is not rare. The surgery did not fail. The conversation that preceded it was incomplete. And an incomplete conversation before an elective surgery in a patient over 65 is a failure of a different kind, one that is entirely preventable. And that begins with the question that most patients do not know. They are entitled to ask, I want to tell you about a patient I will call Helen, 68 years old. Former nurse, which meant she came to every appointment with more clinical knowledge than most patients and more awareness than most of what she did not know. Helen had been living with significant knee pain for 4 years. 2 orthopedic surgeons had recommended replacement. Her imaging supported the recommendation. She was, by standard criteria, an appropriate candidate, but Helen had also watched patients in her nursing career go through knee replacement and come out less functional than they had gone in. And she wanted to understand what she was actually agreeing to before she agreed to it. When we reviewed her full profile together, her controlled hypertension, her mild type 2 diabetes, her body mass index, and her current functional level, I walked her through the specific risk and outcome data for a patient with her profile, rather than the population average data she had been given, the revision rate for her risk category, the chronic pain probability, the realistic functional recovery timeline. And then I walked her through what an optimized non-surgical program would look like for her specific imaging findings, which showed moderate rather than end-stage arthritis. Helen chose to delay surgery and complete a 6-month intensive program, supervised physical therapy 3 times weekly, a structured weight management protocol, and optimized blood sugar control. At 6 months, her functional scores had improved significantly. Her pain had reduced to a level she described as manageable. She and her orthopedic surgeon agreed to continue monitoring rather than schedule surgery. 18 months later, she had not had the surgery. She sent me a message that said, I am not pain-free. I did not expect to be. But I am functioning, I am independent, and I made this decision with real information. Whatever comes next, I know I made the right call for now. Whatever comes next, I know I made the right call for now. That is what informed surgical decision-making looks like. Here is the single most important thing I will say today. A knee replacement recommendation is not a diagnosis. It is a recommendation. And a recommendation, however well-intentioned, is the beginning of a conversation, not the end of one. You are entitled to know the failure rate for patients with your specific profile. You are entitled to know the realistic recovery timeline for your specific body. You are entitled to know what the non-surgical alternatives look like and what outcomes they produce. And you are entitled to take the time to get that information before any decision is made. The surgeon holds the scalpel. You hold the choice. That choice, made with complete information about both the surgery and the alternatives, with honest numbers that reflect your profile rather than population averages, is the most powerful intervention available to any patient over 65. Facing an elective surgery recommendation, more powerful than any implant, more powerful than any technique, the informed patient, asking hard questions and refusing incomplete answers, changes outcomes before they step into the operating room. 4 questions. Write them down. Bring them to your next surgical consultation. Question 1. What is your personal complication and revision rate for this procedure in patients over 65 with my specific health conditions? Not the national average. Your numbers. In patients like me, a surgeon who operates with confidence and integrity will answer this directly. Question 2. What does my realistic recovery look like? Not average recovery, but recovery for someone with my age and my specific health profile. Physical therapy demands, timeline to functional independence, realistic pain trajectory, specific answers, not generic reassurance. Question 3. What would a structured non-surgical program look like for my specific imaging findings, and what functional outcomes would you expect at 6 and 12 months? If the answer is that non-surgical management is not appropriate for your severity, ask for the specific clinical reason why. Question 4. What prehabilitation program do you recommend before surgery, and what targets do I need to reach to optimize my recovery outcomes? If prehabilitation has not been discussed, this question opens the conversation that should have started at your first appointment. Before you close this video, write down one of those 4 questions, the one that feels most relevant to where you are right now. The next time a surgical consultation happens, that question in your hand changes the entire conversation. Which of these 5 risk factors surprised you most? Tell me in the comments. I read every one, and I want to know what information is reaching people and what is still falling through the gaps. And if someone you love is sitting with a knee replacement recommendation right now, a parent, a spouse, a close friend who has been told surgery is the next step, send this to them, not to tell them what to decide, to give them what you now have, the specific questions that make the difference between a decision made on population averages and a decision made on honest information about their specific body. That one share might be the most valuable thing you do today. Everything shared in this video is based on published clinical research and over 20 years of direct experience in surgical medicine. It is general medical information and is not a substitute for the guidance of physicians who know your personal history, your imaging, and your full clinical picture. Do not make any decision about knee replacement surgery to proceed, to delay, or to decline based on this video alone. Bring these questions to your consultations. Bring someone who can listen alongside you, ask for time, and ask for specific answers. You are entitled to both. The goal here is not to discourage surgery that would genuinely help you. Knee replacement for the right patient at the right time with the right preparation is a remarkable intervention, and I would never suggest otherwise. The goal is to make sure that if you have this surgery, you are having it as the most informed participant possible with honest numbers, a realistic recovery picture, and full knowledge of the alternatives you considered before deciding they were not right for you. You deserve that conversation. Demand it before anyone picks up a scalpel. Take care of yourselves. Stay curious. Keep advocating,